So Daniel, I mean, you have dealt with Bermuda, you have dealt with Kenya, well, dealing, maybe I should say. So, in terms of the specifics now, in terms of things like the food that's eaten, what are the general principles that apply?
Well, when you look at the whole principle of application, I think it's good to reflect back on what really causes type 2 diabetes. We know very well consumption or increased consumption of carbohydrates or sugary foods or processed foods trigger your insulin that is from the pancreas, and therefore with time or over time you get into insulin resistance and you gain weight and you begin having symptoms of maybe tiredness, you feel fatigued, and then if not well checked, you move from normal to pre-diabetes to diabetes. If you now reflect back on what we need to do to be able to tame down on the insulin resistance is actually promoted more on the carbohydrate or foods that are converted to sugar, because that's what triggers your insulin production from the pancreas. So the general principle, when you look at it, is just a reduction in the amount of carbohydrates or the sugary foods or the processed foods that you consume. So it doesn't really matter where you are, whether you're in the Caribbean, whether you're in Africa. Just look at the contextual, the food, whether it's your cultural belief, whether it's the food that you have, and look at the foods that we consume. I'll quickly just go through Africa, and especially here in Kenya. When you look at our different communities, we have 42 different communities in Kenya, and we tend to have very starchy foods. We tend to have our cultural foods, our staple foods are actually starchy foods. And one community stands out, and that is the Maasai community. I don't know whether you've heard about them.
Yeah.
They actually consume, their staple food is meat. But when you look at that population compared to the other communities, like the Kikuyus, the Kambas, the Luyas, the coastal region, we have a lot of starchy food. One of them is ugali, or the fufu that people commonly refer to. Depending on where you are, it is actually made differently, different flours, but at the end of the day, it's a starchy food. When you go to the coastal region, it's mainly the rice. If you go to the central region, it's mainly something we call githeri, or the potatoes. So it's mixed beans and maize together, and they actually add potatoes on top. So when you look at that concept, then you would start actually to now understand why overweight and obesity and eventually type 2 diabetes is actually increasing in these populations. And therefore, it is just the same principle, because the advantage we have over the other, if you ask me, the biggest advantage we have as an African community is the availability of the alternative. It is cheap, it is available, it's actually in your garden or in your farm, or what you call small areas of farming here in Kenya. We have lots and lots of vegetables.
So I'm gonna bring Douglas in terms of the UK experience. Daniel very clearly, although we don't have access to the farm, is about the vegetables, yes? It's about the protein. Could you say a bit about what that's going to look like for African Caribbean populations in the UK?
In terms of the UK, there are alternatives. Alternatives to starchy foods in our diet. Most often than not, we will eat things like our yam, our plantain, and our fufu and pounded yam in the Nigerian community as well. But we also love our jollof rice. So it's just about, nobody is saying you should stop eating them at all. And that's not what Daniel is saying. What we are saying is, in terms of what you put on your plate, try and balance it such that the starchy foods are less on your plate. And so an example that we can give will be some jollof rice. There are people who will have jollof rice with fried plantain, with some chicken, and a little bit of salad, with a plate all full. And what they do is they put the jollof rice on the plate first, fill it up, and then the rest will be on top of it. So the advice I give people is, first of all, try and use smaller plates. But also, when you are dishing out your food, dish out your salad or your vegetables first on the plate, so that there's not much room for your starchy foods and the rest. So once you've done that, again, don't put one food on the other. Try and separate them out so that you have a visual representation of them on your plate. And in that, at least let a quarter or half of it be your vegetables.
And that same thing applies to the Caribbean community as well. So we're talking about rice and peas, we're talking about yam, we're talking about plantain, we're talking about green banana, we're talking about those starchy vegetables. But you can use things like callaloo, you can use things like spinach, broccoli, you can use any different green veg in particular to substitute. And as you said, Douglas, putting that on the plate first is just a quick and easy tip, an easy way to reduce that overall carbohydrate intake, and that will still yield some benefit. Yeah. So I said about this is an individual thing. You need to work with your healthcare team. Does it have to be a specialist in remission to enable you to do this?
So my thinking is that remission should be part of the interest for every person who sees people with type 2 diabetes. So because many people with type 2 diabetes don't have the opportunity to see specialists, I think remission, the conversation at least, could be started by all of us, all clinicians. However, there are some aspects of remission, depending on the approach that the person is taking, that might need the specialist input. So, for example, if they are going to do a low carb diet or a meal replacement diet, the thinking is that medications, especially the medications that can induce hypos, need to be looked at, and that might need a specialist input to do that.
Okay, brilliant. Thank you. So, Daniel, fantastic photos making me feel hungry. So, tell us how. What are the specifics?
So sometimes I'll be quick. So where I begin with my patients is just to show them how best they can do this. And I usually go through this cycle here. I don't know where we are beginning from, where we are going to transition, and then where we are going to maintain focus or try and maintain when we achieve the remission or where we achieve our goal. And then always we will be ready to tackle the relapses, catch them early, no blame, no such. So usually that's where I begin. And then I on purpose, when I'm going to hotels or somewhere, I always, or eat out, they always ask you, do you want, this is nyama choma, that's roasted meat and kachumbari and some vegetables. And then they give you this blended juice that they have mixed all types of fruits together. And then, of course, the ugali or the fufu is on top. So I tell them, can you try as much as possible to eliminate the two and enjoy a meal on your left? So that has worked best. Sometimes this is a meal that I cooked at home. Just tell them, look, can you just eliminate the fufu again? And it's much easier when the patient visualizes this. And they're like, are we not going to get hungry? Then you just need to reinforce the fact that, yes, at the beginning, you're going to feel a bit hungry, but as it goes by, you'll feel much, much better. And then I'm in the book of forming this book, which looks like the Wild Foods book. It's an amazing book. I got the concept from Yellow and his partner. And most of our foods tend to be concentrated on the last meal down here. Sorry for the disruption in terms of its clarity. But I always say the lesser carbohydrate you take, the better. So I ask them, where is your food consumption here? And they always point to the last one here. I tell them that is almost equivalent to 32 teaspoons of sugar. How about you go to 23 and then you go to 13, or you completely go off like what I had shown you? Then I always have to remind them, remember, fruits can also have a lot of sugar. So you also need to do the same. Like instead of eating 3 bananas at once, just eat 1. Like 3 of them can be equivalent up to 19 teaspoons of sugar, as shown in this picture here. And then you just go to 1. Or I find these young ladies, young build between 18 and 20, young, let me say the young population, they believe the fruits are really good, and they are good. We never say, and there is nothing bad that can be eaten. However, it's good to remember that mixed fruits can have a lot of sugar, so we need to be watchful. Like this combination here can be up to 20 teaspoons of sugar, and yet this one can be about 9 teaspoons of sugar. The same will now apply because there's a lot of cultural beliefs to something like honey is good, it's fresh, it is nice. But when you show like 5 grams is equivalent to 1 teaspoon of sugar, a cake is, it's way on the roof, and brown sugar is still the same as white sugar. So when you're having such resources, and then you turn the head back and you tell them that egg that you knew was not good is actually good. And look, they don't have a lot of sugar and you're still getting the same amount of energy. So I focus here on the energy because there's the bit that, you need calories to exist, you need calories. So I tell them you still get the same calories that you are still looking for. Here is where I was talking about. We have this thing, omena. I know I've never seen omena out there in the US, in the UK, or in Bermuda. These are so common here. They are very small, tiny fishes, and they are actually zero in sugar. And then when you look at the traditional vegetables, are really, really good. So yeah, that's about it. So it's just
Brilliant. That is so fantastic. Honestly, in summary, what would you like to leave us with? So I'm going to go to Daniel first of all and ask you for a few points.
Yeah, I think first of all, I would just want to thank Diabetes Africa for having organized this, and to all the listeners. I think we are in a new decade, in a new world, just like we are talking about ChatGPT, I don't know, BAD, or whichever technology we are talking about. This is an amazing world right now we are living in. And it can't be any better than giving somebody hope then type 2 diabetes is not a life sentence. It's a lot of hope. And now with a few adjustments in your lifestyle and increasing your physical activity, you can actually put type 2 diabetes into remission. It doesn't matter which community you come from. All you need is a professional who understands how to regulate your medications, change your lifestyle, increase your physical activity, and you will attain your goal. So thank you so much for having me.
Thank you, Daniel. And Douglas, anything else that you wanted to add?
I think Daniel has said it all. But just to add that remission is a reality for many people with type 2 diabetes. So clinicians should be more interested in it than previously. How we approach remission should be at every opportunity with a person with type 2 diabetes. First opportunity might be a diagnosis. Second opportunity might be at the point of prescription. Another opportunity might be reviewing their medication. Before you add another medication to somebody with type 2 diabetes, you speak to them about remission. You refer them to local services that can help them to work towards remission, because the old way of looking at type 2 diabetes, where we keep on piling medications, we keep on thinking or hoping for type 2 diabetes to be worse and for complications to manifest, has changed. We need to spread the word as much as possible that remission is possible for many people. And for those who are not able to achieve remission, Halfway might be that their HbA1c gets better, and that inevitably will help them reduce the risk of complications. So thank you, Diabetes Africa, for prioritizing this topic, and hopefully this should go out to as many people with type 2 diabetes as possible, but also to people who have clinical background, so that their interest can be whipped and that can translate into practice. Thank you.
Amazing. And to amazing experts, thank you so much. Hope, opportunity, and always, as an individual, work with your healthcare team to do this safely, because that is really important. Thank you so much.
Pleasure.
It's a pleasure.